Welcome, everyone. I'm Myra Martinez, patient advocate at United Porphyria Association. I live with acute intermittent porphyria myself. Today, we have the rare and profound privilege to host a true pioneer in porphyria medicine, a physician, a researcher whose work has helped shape more than 50 decades of progress in porphyria research, diagnoses, treatment, and patient care. We thought this was an especially meaningful timing for this conversation because more than 40 years ago, in this very month of July, panhematin was approved by the FDA. That milestone gives us a wonderful opportunity to look back at one of the most important advances in porphyria treatment while also reflecting on just how far the field has come. Dr. Bonkovsky, Herbert Bonkovsky's career has spanned both acute and cutaneous porphyrias, from groundbreaking work in heme metabolism and intravenous heme treatments, from decades of research, clinical care, physician education, and service to patients and families all around the world. His work has never stopped evolving, and I love this about you, Dr. Bonkovsky. His work has never stopped from the moment that he started his research. He has also continued to help investigate and advance novel treatments that are shaping the future of porphyria care today. In 1971, Dr. Bonkovsky co-authored landmark research documenting the use of intravenous hematin during a severe acute porphyria attack, helping lay the scientific foundation for what would become panhematin. Oh, but his story is so much bigger than one treatment. He is a master of the American College of Physicians, a pillar of the Porphyria Consortium, a member of our very own scientific advisory board at United Porphyrias Association, a clinician who has dedicated more than 50 years on the front lines to helping transform porphyria from a terrifying and often poorly understood group of rare diseases into conditions that can be diagnosed, treated, and increasingly managed. For more than 50 years, Dr. Bonkovsky has helped advance our understanding of porphyria across the spectrum of disease, cared for generations of patients, mentored physicians and researchers, helped investigate new therapies, and remained one of the people doctors around the world call still today when they simply don't know what to do next. Please join me in welcoming a pioneer, teacher, clinician, researcher, and extraordinary friend to the porphyria community, Dr. Herbert Bonkovsky. Welcome.
Well, thank you very much. I hardly recognize that person, but I have been privileged over the years to have an interest in porphyrias, which really came when I decided to serve as a research associate and clinical associate at the National Institutes of Health. This was in the late 60s. And I chose the something called the metabolism branch of the National Cancer Institute. That was at that time a sort of a fledgling branch that had been started by Nathalia Berlin, a hematologist, and he in turn had recruited Donald P. Chudy, Tschudy, to be one of the staff scientists. And so Don Schutte was a science nerd. He was valedictorian of his class and president of his graduating class in Margate, New Jersey. Was a band member and was kind of a big man on campus. After he graduated, he got into the V12 program and had rapid education during those war years at Princeton University, getting an undergraduate degree. From then, he went to Columbia University for an MD degree, where he met his wife, excuse me, who was a nurse, and they raised a couple of children and grandchildren and so on. Don um, went to work at the metabolism branch, and I don't know
just how or why he got interested in porphyrias. This was a little bit before my time. I was served as a clinical associate and research associate in the years 1969 through 1971. And his main work at that time was in the porphyrias, particularly in acute intermittent porphyria. And of course, these were the early days, and we didn't know how to treat these people really, and they would come into the clinical center oftentimes very, very ill with paralysis and need for respirators and all kinds of terrible things happening to them. But Don, he was actually the first person to demonstrate a defect in normal. Don was interested in these porphyrias, and we were taking care of increasing numbers of patients with acute porphyric attacks who would come from really around the entire region around NIH, hoping to get some help with what can, as you know, can be a devastating disease. And so, in the a few years before I arrived into the lab, Don and his colleagues had shown that the defect in heme synthesis in acute intermittent porphyria was an increased activity of ALA synthase. That's the first and normally rate-controlling enzyme in heme. Again, the first defect that was demonstrated actually was in this first enzyme in the hemosynthetic pathway, namely ALA synthase 1. And this was a landmark paper that was published by Don and some others in the Proceedings of the National Academy of Sciences in about 1963 or something like that. And he defined it as the first metabolic defect due to an upregulation of an enzyme, which at that time was correct. Although subsequently, a few years later, it was shown particularly by Harvey Marver, who had trained shortly before I arrived at the Chudy laboratory. Harvey moved on to San Francisco. He was recruited by Rudy Schmidt, who was another giant in the field of really academic medicine, but also in porphyrias at that time. And he showed that, in fact, the primary defect in acute intermittent porphyria was a partial deficiency in the third enzyme in the pathway. As you're well aware, you have that deficiency yourself. It has gone by the name hydroxymethylbilane synthase, which is kind of a jaw-breaking word, but it refers to the fact that this enzyme polymerizes monopyroles, these little building blocks of porphyrin to form this first committed tetrapyrrole, four of these strung together to form hydroxymethylbilane, HMBS. It's also called porphobilinogen deaminase. That's an older name, but we still use it. So it then became clear that in fact the primary defect was not in ALA synthase as Don had originally thought, but rather about a 50% decrease in HMBS. And lots of course has happened since then. We now have genetic testing. We know that there are over 700 different mutations that have been associated with acute intermittent porphyria, usually with 50% decrease or so in activity, although it's somewhat variable. There are also fortunately rare, what are called biallelic mutations in HMBS. And these people, unfortunately, often have much more severe or early onset disease with profound um, developmental delay and short life expectancies, although it's variable.
Absolutely.
But
Before we keep on going, and not to interrupt your train of thought, but I'm in awe listening to how Porphyria found you, not the other way around then, from the very beginning
yes,
days.
well,
Amazing.
going back to my days, I was an undergraduate at Earlham College in Richmond, Indiana, and then was recruited into medical school at my hometown of Cleveland, Ohio, at Western Reserve University School of Medicine, which during the years that I was there, or actually the year after I graduated, um, sort of merged with CASE, Institute of Technology, to become CASE Western Reserve as it's known today. So during my time as a medical student, I became interested in heme metabolism and worked in research labs with both Leslie Webster in pharmacology and John Harris in hematology, and worked on various aspects of mitochondrial heme synthesis and roles of iron. And so I was sort of primed to do that, but then really got into the porphyrias, as I said,
And what was
because,
understood, what was the biggest unanswered questions at that time about Porphyria when you first started?
well, I mean, when I joined the Chudy lab, um, the big question, of course, was what exactly is going on in porphyria, and how can we help these poor patients who are having these attacks? So by choosing the metabolism branch and the Chudy lab, I kind of that was really how I got involved in the study of both clinical porphyria. So here I am as a young resident in medicine, trying to take care of these very ill patients, often on respirators and with renal failure and all kinds of things, as well as doing studies mainly in, at that time, rodent models of acute porphyria. And there are a variety of drugs. The time-honored drug was one called sulfonal that had been defined way back in the 1880s as a porphyrogenic drug. This was done by an investigator in the Netherlands who observed that people given sulfonal, which was a soporific, something to help with sleep and sedation, led to dark colored urine and to a marked increase in what we now know to be porphyrin in the urine. At that time, it was not called that. It was a chromophore that one could detect with something called Ehrlich's reagent, which is a reagent that forms a pink color when it's reacted with porphyrin. Another drug similar to sulfonal called allyl isopropyl acetamide, AIA, was our drug of choice. And so I began a series of studies um, in rats given AIA at different doses and assessing what happened, and indeed found, as others in the lab had found, and others around the world had found at that time, actually, that there was a very, very marked upregulation of ALA synthase, often going from sort of normal to 20, 50, 100 times the upper limit of normal. The
Wow.
second thing that we did, and at that time, Don and his group had been studying the importance of nutrition, which
is still important in the porphyrias, even today, even in this day of intravenous heme and glycerin, which we now have, which of course is an enormous advance. But nutrition is still important. And we showed, for example, that if we gave high doses of carbohydrates, glucose, we did it by gavage. So what we did was we took a solution of like 20% dextrose and sort of force fed these rats with the glucose, we could markedly down regulate this up regulation of ALA synthase and really stop at least the biochemical features of the porphyric attack in its tracks. And that continues even today to be of importance. Now, it's
Absolutely.
not as good as intravenous heme, but it's
Let's
not.
talk about that, about the intravenous heme. I don't want to keep on moving forward without going back to where did this idea come from? At what point, as you're studying the pathway more closely, does this idea come from to you that says,
Yes.
give
So
is
so the whole
limited?
idea of heme, what we were learning at that time was, and this was really mainly by um, comparison or by similarity with studies being done in microorganisms, particularly a microorganism called Rhodopseudomonas pheroides, which was being studied by June Lascelles, who was a microbiologist at UCal Berkeley. And they had shown that there is an end product repression of ALA synthase in the Rhodopseudomonas pheroides. So this is a microorganism that has many of the same enzymes and the same characteristics as does mammalian human biochemistry. We know that biochemistry is remarkably preserved across species and across the eons of time. And so that led us to say, well, um, heme is a repressor of the synthetic pathway. And that was really the fundamental insight that the end
That's what
product
made me think. That's what made me
is
think that it was going to be
responsible.
possible.
Yeah, yes, exactly. So, and so um, we were um, doing these studies. We had studies supporting that in these rodent models. We knew that heme was capable of repressing the induction. We knew that other drugs such as estrogens, progesterone, were capable of inducing, but we also knew that there were these circadian rhythms that were going on, so that there would be upregulation followed by some downregulation. And it was obviously a very dynamic pathway. But in any case, that led to the whole idea that, gee, if we have a really sick patient, why don't we try giving heme to the patient to see if it might be of help? We had tried everything else. We were giving lots of carbohydrates. We were doing all the nursing things we could. And yet we had, in particular, a very sick patient who had been at the NIH for months and who had gradually worsened despite our best efforts at treating with everything we knew to do. And so I eventually convinced Dr. Berlin, Dr. Chudy, other leaders in the metabolism branch, that it was worth our trying at least to see what intravenous heme would do. But of course, then I needed some intravenous heme. So what I did was I went to the blood bank of the clinical center, and got some outdated human blood that was no longer going to be used for transfusion. And I set about to crystallize and recrystallize the heme using fairly standard methods, which were detailed in our original publication in the PNAS, which that paper appeared eventually in 1971 in the Proceedings of the National Academy of Sciences. And so I did that, and I got enough heme together and recrystallized it, working all night, so that the next morning we could give it to the patient. And indeed, we did that. And lo and behold, we found that there was this dramatic and very rapid down regulation in plasma, ALA, and PBG. Now, we needed to send at that time the plasma samples to the laboratory of Dr. C.J. Watson in Minneapolis. Dr. Watson was very interested in porphyrias and had worked on the porphyrias for a number of years. He had actually been a fellow with Hans Fischer back in the 30s, one of the pioneers in the whole field of um, porphyrin and heme chemistry. In fact, it was Hans Fischer who had um, determined the structure of heme, for which he won a Nobel Prize. But anyway, um, so this patient had renal failure, so there was no urine output, and we were measuring ALA and PBG generally in the urine. We had not developed plasma assays, but a guy working in Watson's lab had done that. So we sent the samples to them, and they confirmed that there was this dramatic and almost immediate fall after a single dose, and it continued after several doses. And so, with that result, I literally went into the business of purifying heme from outdated red cells and trying to make enough heme to provide the demand for this patient. And I did that for some period of time with overall, as time went on, diminishing results, but still with down regulation. Unfortunately, the patient did not recover. She was paralyzed and in renal failure and just very, very ill. So we weren't able to save her. But then I went on to further training elsewhere, but the work was then really continued in the early days, primarily by Joel Lehman, by Richard Magnuson, by others working who followed me at the Chudy Laboratory. And by 1983 or so, um, the Don Chudy and Joel Lehman and others had kind of talked Abbott Laboratories into agreeing to begin to produce heme for human use. And of course, at that time, Abbott was a major provider of um, um, blood products and so on. So it was kind of a sideline for them, but they were very good about agreeing to do that, and we really over the years have much appreciated that. And as I think you know, that eventually led to actually the first orphan drug designation of
Which was not the easiest thing to do, I'm sure, back then. You know, we get little attention now as it is with
yeah,
some rare diseases. I cannot imagine what the 70s, early 80s was like. And honestly,
yes,
I have to
yes,
tell you, as I'm listening to your story, Dr. Bonkovsky, I'm imagining this young Dr. Bonkovsky who has so much hope and full of energy trying to solve this new idea that was given to you. I honestly believe it was a God-given idea to you to test this on the very first patient. And we know the result, but I can just imagine you next to this human that is meeting a scientist, a doctor, a young doctor with so much full of hope and expectation. Meanwhile, this person is very similar to many of us who have suffered acute attacks, paralyzed, like you said, renal failure, maybe even liver failure. And here's this young doctor who is like right there watching this unfold. Were you physically in the room infusing this patient for the very first time?
Yeah, it was an interesting time, that's for sure. That's for sure. Well, anyway, that of course that was picked up fairly quickly, and Dr. Watson and Klaus Pirach and others began to make their own heme. They didn't realize, though, that something that we didn't fully realize until later as well, and that is that intravenous heme, it's not so easy to get into solution. It's not soluble in water. You have to use either a fairly strong base, such as sodium hydroxide. We chose sodium carbonate, which is not quite as strong a base, to redissolve it. And that's why it's called hematin, by the way. Heme, uh, it can have different anions. It could be a chloride ion, in which case it's called hemin. But usually, when one dissolves it in either sodium hydroxide or another base, such as sodium carbonate, the anion that neutralizes the positive charges is actually a hydroxyl radical or hydroxyl ion. And that is the reason why the most nearly correct name actually continues to be hematin. And that was just something that was named by an Australian biochemist back in the mid 50s, and it's stuck. And it's, as you know, is still called hematin, or the brand name is pan-hematin, as it's available now from Recordati in the U.S. Others fairly quickly who were working in porphyrias picked up on it. So Monty Bissell was sort of cajoled into developing some hematin for people out in San Francisco in the Rudy Schmidt group, and he did some early work. But he and others, and we later showed that unfortunately it's quite unstable if you reconstitute the heme in um, sterile water
Mhm.
or without the use of albumin. And we continue to this day to recommend to our colleagues that rather than reconstituting the panhematin in sterile water, as is still officially recommended in the package insert to this day, that rather it's better to reconstitute this in human serum albumin, 25% human serum albumin. And the reason is that albumin binds to heme and it stabilizes the heme. It keeps it from undergoing these um, various reactions that lead to both reduced potency and activity, but also to increased adverse side effects, particularly adverse side effects on blood clotting. Now, that has never been officially accepted and approved, unfortunately. Recordati doesn't want to get into the business of trying to change its package insert, which it's had around since 1983. But those of us in the field are quite convinced that it's better actually to reconstitute the heme not in sterile water, but in human serum albumin, and it stabilizes it and it continues to be effective. So what the heme is doing is that it is getting into hepatocytes and
Got
it
it.
is repleting a deficient critical regulatory heme pool and leading to down regulation of this first and normally rate controlling enzyme, namely hepatic ALA synthase. And it turns out that acute porphyric attacks have to occur. I mean, they only occur in the setting of this uncontrolled upregulation of hepatic ALA synthase. We now know that, fortunately, most people who have genetic defects in HMBS never develop any acute attacks. We estimate only about 2 to 3% are unfortunate, as you have been, Mayra, to have had these acute attacks. Um,
Right.
and most people go through their lives with no attack, or maybe they have one attack. If the diagnosis is made, they can avoid further attacks by doing the right things and, if necessary, receiving intravenous heme. To this day, we don't really fully understand why some people are so much protected versus a few, 2 to 3%, who have these acute attacks. But the short answer is that intravenous heme, as either panhematin or I haven't mentioned heme arginate, but heme arginate is the sort of the alternative form of heme that's available not in the US, but in most of Western Europe and many other countries. And it was developed by Reino Tenonen, who was a biochemist working in Finland. Reino started with um, blood from the Finnish Red Cross and did a bit of a different approach. So he added arginate, he added some ethanol, to make a long story short, he came up with a somewhat different formulation from the lyophilized powder cake that we developed as panhematin in the US. And the nice thing about hemarginate in some ways is that it is a concentrated solution. So it's available in ampules. Um, it can be diluted into normal saline, although most experts in Europe also recommend that it actually be reconstituted into human serum albumin because it too is quite irritating to veins. It can cause thrombophlebitis. It can cause phlebosclerosis, all these problems. And so that's really the big reason why we, to this day, recommend that if people need to get either heme arginate or panhematin, that they best receive it either via a PICC line or via a central port into a high flow vein, because we've had far too many patients who have received these into small peripheral arm veins and sometimes leg veins who have developed they really chewed up all their peripheral veins by
Why
receiving.
is it? Why is it, Dr. Bonkovsky, that it aggravates the veins so badly? I've had that happen to me myself.
Yeah, it's not terribly well studied, unfortunately, Mira. And over the years, I have urged Ray Cordati to support further studies, but Ray Cordati has not. It hasn't been a matter of priority for them. But I mean, we do know that heme in general is quite redox active, so it increases oxidative stress. It increases reactive oxygen species. It also leads to a marked increase in patterns of protection, particularly there's an enzyme called heme oxygenase, which is that turns out to be the first and rate controlling enzyme for heme breakdown, which was at the time that we did these original studies, heme oxygenase had not been discovered. It was characterized in the sort of the early mid 70s, again in the Rudy Schmidt laboratory, and so it turned out that uh, giving intravenous heme leads to a tremendous um, downregulation of hepatic ALA synthase, but also a tremendous upregulation of this enzyme heme oxygenase. And a number of other anti-inflammatory, anti-fibrotic things. So to answer your question in sort of a hand-waving way, it's clear that uh, lots of heme floating around sort of unassigned, while it's important to downregulate hepatic ALA synthase, which it does by a variety of mechanisms, and we can get into those mechanisms, but it also does have many, many unwanted side effects. So it's certainly not the kind of thing that you want to just take willy-nilly. If I'm feeling a little bit off, let me take intravenous heme today. It should only be given for people that are having true acute porphyric attacks. And we continue, unfortunately, even today, too often to see patients who have been misdiagnosed and have been overtreated with intravenous heme and with heme arginate. So I want to stress it's very, very important not to miss the diagnosis, but also not to overdiagnose porphyria. In our clinical experience, I would say about 90% or so of people who come to us supposedly with a diagnosis made elsewhere of acute intermittent porphyria, by the time we finish the evaluation, we generally tell these patients that their diagnosis was incorrect. So there is a continued problem, without question, of both underdiagnosis, misdiagnosis, people suffering, having attacks, and the correct diagnosis hasn't been made, but also people in whom they have some abdominal pain or they have this or that, and people get some mild increase in urinary porphyrins and jump to an erroneous diagnosis. So I urge patients, if you think you have or you may have acute uh, porphyria of any kind, whether it's acute intermittent porphyria or hereditary coproporphyria or variegate porphyria or this rare ADP deficiency porphyria, please get a clear diagnosis made, best done at a center of excellence and with genetic testing, and find out exactly where you stand before embarking on what might be adverse effects of excess intravenous heme. So heme, even to this day, as you're aware, is still considered the treatment of choice for acute porphyric attacks that are severe enough to require people to be in the emergency department or admitted to the hospital. It is certainly not a cure. Usually we give it at a dose of 3 to 4 milligrams per kilogram of body weight once a day. Giving higher doses has not been shown to be of additional benefit and does increase risk. There have been at least one instance of acute liver failure requiring liver transplant in a patient given 6 milligrams per kilogram body weight of intravenous heme. There have been at least one or two cases of acute renal failure occurring when higher doses. So the idea
that if 3 milligrams per kilogram per day is good, 6 or 10 is better is incorrect. And you have to be careful with not giving too much intravenous heme. But usually after 3 or 4 days, along with good nursing care now, and with particularly avoidance of the many drugs that can increase hepatic ALA synthase, the most important of which continue to be progesterone, um, barbiturates, hydantoins, really anything that is a strong inducer of the cytochromes P450 also tends to upregulate hepatic ALA synthase and is a strong contraindication. And of course, there are many, many drugs and more being developed all the time, so that the best advice that we can give to patients is avoid the ones that we know are these potential risks. If you have new drugs, check the drug list in porphyrias.org. Many drugs are not carefully studied and are best avoided, although it's always, benefit versus risk. And if a drug is felt to be absolutely essential for a patient, even though it may be porphyrogenic, I wouldn't say that it is absolutely contraindicated, but it needs to be given with a lot of thought. And fortunately, now that we're not using barbiturates or hydantoins as much, and we have other drugs such as Keppra, levetiracetam, for treating the seizures, which used to be such a big problem because until we had levetiracetam, we didn't have much to treat seizures, which occur, unfortunately, in 20 to 30% of people with acute porphyric attacks. And we knew that barbiturates and hydantoins, which were the things that we usually use, were very, very dangerous and contraindicated in these patients. And we used to use bromides, which were pretty miserable, although they did work, but with lots of side effects. So the ability to treat the seizures with levetiracetam, with Keppra, with doses of magnesium hypomagnesemia is often a problem. We haven't talked about hyponatremia, which is often a problem, but good nursing care, good medical care continues to be absolutely essential to try to help these patients through these acute events. And then, of course, now, since about 2019 or so, we have this very exciting addition of gavosarin, this siRNA that specifically and selectively downregulates hepatic ALA synthase in a way even more specific than that of intravenous heme. And that has been not a cure, but it has been a godsend to patients who suffer these recurrent episodes. And so in most places, I think, including the US and Western Europe now, we can generally get approval for the very expensive subcutaneous gavosarin for patients that are having at least 2 bona fide acute porphyric attacks within the prior 6 months, or at least 4 within the prior 12 months. And this has been life-changing for many patients. I don't know, Mayra, whether you're using gavosarin.
I am. I went from being miserable and essentially living in the hospital to actually seeing my overall progression of flares go down, down, down until eventually I do get some flares because of my hormones, my menses, but never to the point where I was paralyzed and in that acute attack where 19 or 2018 left me fully, fully paralyzed and on my death
Wow.
Wow.
So I've not
Wow.
been able to experience that, and I'm beyond grateful for givosserin for sure. As
Yeah.
I'm
Yeah.
listening
It's
to you and
terrific.
all of these things that we have had the pleasure of seeing from, that 1971 document that you wrote to seeing the first patient experience panhematin. Here we are now 40 years later, panhematin became available. Your role in particular, Dr. B, has really expanded beyond reach. For decades, you became the available physician to doctors to call when they were completely stumped, because porphyria can mimic so many things, like you have mentioned. And as we know, so many conditions can be mimicked by porphyria. Patients can spend years searching for answers. But looking back at those decades, what did it mean to you to be the person that could be finally the one to help understand what was happening to these patients and help plan a path forward for them?
Well, I guess you're sort of working on things and coming up with ideas, and the general field is moving in a certain direction in this idea about the importance of the regulatory heme pool, and the whole idea that heme might prove to be a therapeutic, is just part of the, I guess, the scientific zeitgeist of the time. It was I guess I was just at the right place at the right time with the right opportunity. And as you say, I had some ideas. Now, I must also tell you that if we were doing this today, it wouldn't have been as simple, because back in the late 60s, we didn't have nearly all of the regulations about IRBs and consents and things like that. So I talked kind of my chiefs, and I thought I had a good scientific rationale, and they agreed, and we were able to move ahead much more quickly than now it would take probably a year to do this sort of thing. Whereas I had the idea sort of one day, and
I'm glad it happened when it did then. It was
a
perfect
week a week
timing.
a week or so later, I was able to give the first dose of heme, and I've just been sort of um, uh, in a way amazed, but also happy to see that now, more than 50 years later, it has withstood the test of time, and it continues to be an important way of our trying to help these patients. And of
Absolutely.
course,
We wouldn't
I
be
got
here today
involved
without
with
you.
other porphyrias as well, and but that's probably the topic for another session. But it's obviously I haven't worked only on porphyrias. I'm a gastroenterologist and hepatologist, and have done lots and lots of studies over the years in viral hepatitis, in autoimmune liver diseases, now in fatty liver disease, which is, of course, a huge and growing problem as well. And another area of longstanding interest, as you may be aware, has been in drug-induced liver injuries. And of course,
Mhm.
these effects on um, porphyria of some of these drugs, in a way, are drug-induced liver injuries as well. So I've been blessed to have been able to be involved, and to continue to be involved, trying to help you and other patients around the world. And it's been a blessing.
And for that, we are forever, forever grateful for sure. I have to ask you something that many people in this community actually know about you personally. After all the publications, all the discoveries, the many leadership roles that you've had, the decades of experience in, like what you mentioned, not just porphyria, but many other areas of interest, you still answer the phone. physicians around the country, around the world, they still call you. And patients who might be stuck in a certain, scenario, their doctors might call you regarding like, what do I do next? And you still pick up the phone. Why?
Well, I guess it's something that I've just done and trying to help patients. That's really it. I mean, not that we always succeed, that's for sure. Unfortunately, there continue to be these terribly, terribly sick patients. There's a very sick young woman in India right now that we've been working on and doing the best we can. And I was very, very disappointed that El Nilam refused to provide compassionate use gavasarin for this child, this poor child who's paralyzed and just not responding to the hemarginate they're giving. They're doing, I think, everything they can in India. So we even today, unfortunately, there are patients that for whatever reason we can't save. And of course, liver transplant always comes up when our backs are really to the wall. And we're doing far fewer liver transplants, although, as I think you're aware, liver transplant for classical acute intermittent porphyria is curative.
Hmm.
And so if you take out the liver with a 50% decrease in HMBS activity and replace it with a normal liver, a liver without defect, the disease melts away entirely, biochemically and clinically. However, it's high risk, high reward. I mean, there's a risk that you won't survive the liver transplant. And unfortunately, this little girl in India is totally paralyzed on a respirator. And I mean, there's just no way that she could ever survive a liver transplant. So, um, there are these patients that we still can't save, and it's we don't uh, we don't really understand why. They it's I mean it continues to be a very puzzling disease, and there's an awful lot that we still don't understand. Why do only 2 or 3% of people develop symptoms, and yet why do some have such severe symptoms? Um, um, it was named um, the little imitator. Have you heard that phrase?
Yeah.
Yeah, the
Yes,
little
absolutely. Because it
Jan
does
Jan
mimic so
Jan
many different.
Voldenstrom was a mid 20th century outstanding internal medicine doctor. In fact, he I think gave the name acute intermittent porphyria to this syndrome. Jan was Swedish, and of course, there's a lot of acute intermittent porphyria in the north of Sweden. And so he named that, he named Porphyria cutanea tarda, and he called it the little imitator because it could look like so many different kinds of diseases. And as you may or may not be aware, um, the the big imitator back in before we had penicillin was syphilis. So the big imitator syphilis, which could look like anything, the little imitator acute intermittent porphyria, the little imitator.
I actually did not know that. I did notice something though that I don't want to let by without mentioning. You got emotional over the situation about this little girl, and that to me is so profound, Dr. B, because oftentimes we see a doctor, a scientist, but we don't see that human side. You get to take this home with you. This affects you, and for that we're so grateful that I'm sure that has been the biggest drive to get you to have poured so much into our community the last 50 years. When I look at where the field was as a whole, where when you first started, to the greatest progress that was made with you in it, my heart just boasts with so much gratitude because it was your contribution that has allowed us to get to where we are today. And, just watching you as a human being beyond more than just a doctor, a scientist, thank you. And I really do mean this from the bottom of my heart, from every acute patient that you have touched to every cutaneous. As you mentioned, you have been involved with not just the acute side, but also the cutaneous. You had a lot to do with EPP, liver complications, all of these research that we could readily find just by typing your name, Hubert Bonkovsky, and boom, there's a whole bunch of publications of things that you impacted this community with. I'm cognizant of the time, but I wanted to take that moment to acknowledge you as an individual and thank you for all the investigation that you've done, for all the incredible work that really, when I look at the landscape of this disease, we wouldn't be where we are today if it wouldn't have been for you and everything that you've
All right.
done.
Well, great,
You
great,
made
great.
me get all emotional.
Glad to be available. It's great to talk with you, and I hope you do very well and can
Thank you.
stay away from further severe attacks and stay on that gavasarin.
Yes, it is working out really well for me for a brief second, just because I got to talk to you at IPS the last time, and when we last spoke the last time, I was on the path to getting a liver transplantation. But you mentioned something during this call, and that is that oftentimes we can get a lot of liver complications by our own drugs that we're taking that we might not even realize. We might be taking too much panhematin. We might be could be taking more opioids than what we need. A combination of multiple things allowed me to avoid liver transplantation. And I say this out loud because it came up on this conversation today. Love my doctors, but it took a true expert. I can say his name because he's one of our scientific advisory board members as well. Dr. Bruce Wang saw my case and he said, "You don't need to be on liver transplantation. What are you talking about?" And I am doing significantly better. I've avoided the transplantation. And this is a warning and really a call to all the patients out there that if you are second guessing what your treatment plan is, we have multiple locations around the nation for you to be able to get in contact with one of these experts. And the UPA is here to help you connect with those experts so you can get the best treatment plan. And Dr. Bronkowski is not going anywhere. He's still a phone call away. Isn't that right, Dr. B?
Well, I hope that
He's hesitated on that
it,
one a little bit.
um, and yeah, I mean, and it is true that gavasarin is not a cure. Heme is not a cure. There can be breakthroughs. We're continuing to try to prevent those from happening, do everything we can. I won't say that maybe there still might be a rare indication for a need in a highly selective person, even with gavasarin and intravenous heme, either heme arginate or panhematin for liver transplant. But I'm pretty sure that we're not doing nearly as many liver transplants for acute intermittent porphyria as in the pre-glycerin era. I haven't seen any actual good data on that, but it would be an interesting topic and worthy of further formal study. But
Absolutely. We're coming close to the very end and we have surpassed just a few minutes, but I do want one last answer out of you and then we'll move on to the closing. And that is, how do you see established treatments like panhematin working alongside with newer therapies as we move into the future of porphyria care overall?
well, I hope that we'll have less need for intravenous heme. It continues, as we know, certainly not to be a cure-all. It it has adverse side effects, and yet it is still important. It's still of benefit for patients when they need it. But of course, prevention is always better than treatment and cure. And so early diagnosis, avoidance of porphyrogenic drugs. I mean, we now know that stresses of all kinds, and they aren't necessarily physical stress, it can be psychological stress, can be very, very important in causing acute porphyric attacks. So trying to get people not to be stressed out, of course, that's easier said than done, and we all live with life stresses. But plenty of rest, good nutrition. Don't ignore the importance of this glucose effect, the effect of proteins and carbohydrates to downregulate this hepatic ALA synthase continues to be very important as well. So I mean, these diseases are going to continue to be with us. The people I would say that have the biggest problems tend to be those in whom the diagnosis is missed and they receive barbiturates, hydantoins, progesterone, other inducers. And yet there are these unfortunate people around the world who sort of through no fault of their own continue to suffer and sometimes die, unfortunately. And all we can do is that we'll continue to do the best we can to try to help relieve and prevent that suffering from occurring.
Absolutely. Well, that definitely makes sense. And alongside also, thanks to our pharmaceutical companies who continue working really vigorously to ensure that we get the best therapies, the best treatments possible in conjunction to all the research that we have mentioned. Of course, we just talked about how you have spent half a century of your life asking difficult scientific questions, caring for patients, teaching physicians, mentoring researchers, investigating new therapies, and helping us move the field forward. I know that everyone that is listening here, I can see the messages in the chat saying thank you, calling you all sorts of beautiful names because you have made a huge impact in all of our lives. And before we part ways, Dr. B, I have a surprise for you. If you are on mute, Jillian, take yourself off mute. I actually have a patient of yours who you just recently saw, you recently treated, and she happens to be one of my favorites I have many favorites, but one of my favorites in our AHP focus group that we meet every Wednesday. And she is here and she would like to give you some words. Jillian?
Okay. All right. Hi, Jillian.
Can you hear me?
There you are. Yes, we can hear
Yes,
you. I know we
yes,
can't
All
see
yes.
you,
right.
but
Let me
we
get
can.
my camera on.
Hi, Jillian. Hi.
Hello, Dr.
Nice,
B.
nice to see you. Nice to see
It
you.
is so good to see you. So I think I have the benefit of maybe being one of the last patients you took on at the clinic. I'm not sure. But we met just a little over a year ago, and I had been
Yes. Oh,
having,
I remember you well. Yes, yes, of
well,
course.
I had been having attacks for a year and a half, and nobody could figure out what was going on. And finally, I was hospitalized, and I saw a GI in that hospital, and he had done his residency, Dr. Wilson, Joshua Wilson, years ago, had done
Yes,
his
yes.
residency at your clinic. So he knew to look for porphyria because of having done his residency with you and near you
Yeah, yeah.
in your clinic. So I benefited in that way. But then when they discovered it, I, you know, I was passed your name as somebody to try to reach out to. Now, I tried Mayo Clinic first, and they said they would not take me on as a porphyria patient. And I was discouraged and afraid nobody would take me. But when I was passed your name and I called your office, it was immediate. They said, "Can you come tomorrow?" And I said, "Yes." And you were seeing patients on Wednesdays. And it happened to be a Tuesday. They said, come tomorrow. And you're 3 hours from where we lived in South Carolina. So we drove the 3 hours to come see you. And immediately, you were the first doctor I encountered in that year and a half of being so sick and losing so much quality of life and not participating in my daily life. Um, you knew porphyria, and suddenly you knew what to do and you knew what to talk to me about. And I wasn't the one teaching my doctors, I wasn't the one telling you what I needed. Finally, you were speaking to me and giving us the answers, and you continued to teach. You were available by email. You taught my local hematologist, Dr. Korapati, and she just adores talking to you. And you've been available to her. And because of that, I think I am getting the ideal daily care on the regular basis that I need, and everything was afforded to me. But not just that, but you solved what my mom had. And my mom is the one who did not make it with this disease. We never knew what she had. And she ultimately took her own life after 7 years of serious illness back in the
Yes,
1990s.
yes. Wow.
So, generationally, you have now solved a mystery for my family. And we've now been able to test my children, and we have the results for 3 out of the 4. So far, 3 out of my 4 children do not have the gene.
Oh,
But we're
good,
thankful
good.
to know that. Yes. And
Yes,
so you
yes.
have been an absolute blessing. So we've heard all your science, we've heard all your research, but then we hear you get choked up because you're dealing with real people and real patients and making a real difference. And so I just wanted to share my family's gratitude for what you've done to solve a 30-year mystery for my family, and then to improve the outlook and future for myself. So thank you
Oh,
so
terrific,
much.
terrific,
Thank you.
terrific. Listen,
Yes.
try to keep cool. We got another heat dome heading our way.
We do. We do. That's a
uh,
tough one. Yes, it is.
all right.
Oh, well, you're the best, Dr. B. I'm not the only person who
Thanks so
feels that
much,
way.
Julie. I'm
Thank
glad
you.
things are going well for you. And yeah, geez, I hope that you're so there is one child with the genetic defect. Is that correct? One of the
No,
four?
we haven't gotten his results back yet.
Okay. All right.
So
Well,
so maybe.
I hope nobody. I hope nobody.
Me
And
too. Thank you.
yeah, keep up the great work. And
Th-
yeah, I'm still around. I'm still kicking. So if Dr. Korapati or Dr. Wilson or you have questions, I'll be glad to try to help.
Thank you so much. So
All
appreciate
right.
you.
Okay. So
Thank you
long.
so much, Jillian.
So long.
Thank
Thank you
you.
so much, Dr. B. For the
All right.
listeners, you've been listening to Dr. Bonkovsky, who is truly a titan in our space of porphyria. Just the amount of work that you have done has really touched families beyond what Jillian and her family have experienced. Many of us, even at a distance, have experienced and benefited from all of your life's work, your research, and everything that you've done. So, Dr. Bonkovsky, once again, thank you for your decades of discovery, your service, your mentorship, your commitment to this community. And it has truly been an honor to have you here with us today. So thank you so much to everyone that has been listening. Let's keep moving forward. And, really at the end of the day, let's make sure that this story reminds us that we all have our part to do as well. It can't be just all on the scientists. It can't be all on the doctors. It cannot be all on the pharmaceuticals. We have to do our part as well. Let's share our stories. Let's commit to ensuring that we are creating the porphyria awareness, because that is what's going to help it be recognized much easier. Wouldn't you agree, Dr. B?
Yes. Yeah.
All
Yeah,
right.
glad to still be kicking and making sense at least some of the time. It's good to
You
be
make
with
sense
all of you.
all the time. Well,
All
thank you
right.
so much for your time. We love
Have
you
a
and
good
we appreciate
afternoon,
you.
everybody. So long.
Thank you. Goodbye. Goodbye, everyone.